We're going back to Germany with Andre. Oh, there you are. Hi, Andre.
Yeah.
Can you hear us?
Hello, hi.
Okay, great.
I can hear you. Can you hear us?
I hear you well.
Me? Yeah, perfect. Wonderful, yeah. Yeah, thank you. If you want me to start, I
yes,
can do
please,
this.
please. Yes, tell us what's happening.
Yeah, with me is Marion Czupek. He's one of our interventionists here in the cath lab. And yeah, so if you can show me the slides. The slides, please, yeah. Slides, second case, please. No, yeah, okay. Yeah, so thank you very much for having us also for a second case. Well, here for that case, you were, no, first slide, please. You were requesting a calcified combined iliac common femoral disease. And yeah, I must a little bit apologize. So either I had a case or two cases which were much more complex than the first one, which we've just shown. I thought, no, better here, this is an easier case than now compared to our first one. Maybe rather to relax a little bit. Okay, next, please. Conflicts of interest slide. These are my conflicts, potential ones. So this is a male patient, 71, severe claudication, left 100 meters, ABI, sorry, left 0.6. And he had a stenting here last month. And he has some COPD, former smoker, hypertension, HLP. And next shows you an angiography, which was obtained. So he had some treatment first of a common iliac on the left side in another hospital, not very tight. And yeah, didn't really help so far. And now you can see on the right side, this common femoral artery subtotal stenosis, I would say, very calcified. I mean, it goes a little bit into the common, into the iliac, external iliac, and some disease in the profunda and the total SFA, total occlusion. Yeah, next shows you our intended stretch. Yeah, this is the outflow. And then again, a long SFA, total occlusion, very calcified. So we thought first to treat now common femoral and profunda, and I think this will help him a lot. And then we can decide whether we continue to treat, but I don't think it's primarily necessary here to open up the SFA. Next, please, shows you our intended strategy, go crossover, 8 French. 7 French would be enough for any atherectomy device, but we are planning the jet stream atherectomy, and sometimes the filter is that much blocked and filled that it may be difficult to get out of the 7 French again. So therefore, we thought to start here with an 8 French. Maybe interwoven nitinol stent for the external iliac and a drug-coated balloon treatment for the profunda. Next slide shows you that we want to use here the magic touch balloon, the sirolimus-coated balloon here for the profunda and potentially also the common femoral artery. This is available up to a diameter of 12 millimeter. Yeah, if we can switch to the angio. This is the right groin, very short common femoral artery, and then cross over. This is once again the lesion. Yeah. And of course, very hard to go crossover, very calcified. So we used here 7 by 40 millimeter balloon here to get the 8 French sheath crossover. Once again here, otherwise risk of damaging here the stent and would not have been possible, in fact, to go crossover. Yeah, that's where we are, in fact, and we loaded a filter now, a NYEVS filter, as you can see here, in the profunda artery, which we opened here, the bigger filter. And once again, I filmed here the outflow, sorry. The total occlusion, the poplita has another high-grade stenosis. Outflow is okay. Yeah, I think for us, it's, yeah, why not endo? Sure.
Thank you, Andre. Another great case. Maybe we can go down the panel real quick. Liz. Liz is coming from University of Pennsylvania, assistant professor of vascular surgery. How would you approach this case in your practice, Liz? Would you look at this as a primarily endo case, or would you look more to a surgical option in this case, given the CTOs you're dealing with?
Obviously, I think this is contributing to the patient's claudication, so I think the decision to treat this, particularly with the significant both concomitant common femoral and profunda disease, is really important in contributing the collaterals to the SFA. For me, typically, unless it's pretty prohibitive, redo groin, very high comorbidities that are preventing it, body habitus, this is probably something that I would approach from an open procedure. When you see this kind of lesion in person, it's going to be a really large, exophytic, highly calcified disease, really going to respond well and have some pretty nice long-term durability. That being said, the good thing about this lesion that favors a potential endovascular treatment is that it doesn't involve kind of a bifurcation disease, and so you're not necessarily going to ruin any kind of need for SFA intervention down the road. Probably not at risk of jailing the profunda off with anything that you're going to do. If you're going to end up laying an interwoven stent, you can kind of avoid that bifurcation and potentially treat the profunda itself separately. But for me, I would approach this in an open manner.
Maybe the others can weigh in on, since this is being tackled from an endovascular approach, there's obviously different ways to do this. We've talked a lot about, IVL and the thickness of calcium and calcification, like Dr. Finelli brought up in the yesterday's breakout sessions. Would IVL work here, given the coral reef, dense calcification? We don't have IVUS findings yet. We don't know how thick it is. Lawrence, Dan, anybody?
From the PAD3 data, if you look internally at their data and their angios, they did a fair number of circumferential calcifications, but they also had some coral reefs, and it works pretty well. It's how much you want to. Again, it's not so much lumen gain, which is obviously important, but it's really cracking calcium, and then risk of embolization. And if you look at PAD3, it's a subset. It's really a post hoc analysis, but in their coral reef division, if you call it that, there was little to no emboli. But when you go to the OR, these things are exceedingly friable. And so any manipulation there is going to go somewhere. So I think distal protection is useful. In PAD3, there was like a 1.3% event rate. So it's relatively safe. I guess the question is, and again, I always have championed this for all the years, is this is really a trial that just needs to happen. I think that we've got a lot of registries on common femoral disease, but it's really a nice randomized trial that needs to happen. Get some good interventionalists, get some good surgeons who are willing to randomize the folks and really see what the primary patency is, but more importantly, what the comorbidity secondary effects are, because seromas are sometimes awful, and the recovery from this incision is awful. So I think you're going to win in certain things, and we may lose in other things, but I think it's such a scientific pursuit that we need to have happen, unfortunately.
Yeah, great point. Andre, we know you have an 8 French sheath up and over. Can you talk to us about technique and what your thoughts are in terms of using the Jetstream atherectomy device and why you decided on this versus others?
Yeah, so I mean, Jetstream, because if it's really densely calcified, and here I thought it's really very densely calcified. I, in fact, prefer the Jetstream if I have the impression that I can go through somehow interluminally. If it's more an eccentric plaque, yes, then maybe rather a directional atherectomy. And here it's difficult, to decide. I mean, the profunda stenosis is more what I think I pass through intraluminally, so it's clearly Jetstream for me. It's nice here, but proximal, in fact, it's eccentric. I would say Hawk could also be an option if it's not too calcified. But I'm also, I think it's not a mistake here to later on balloon aggressively and take a short superior here into that proximal common.
What's your thought on IVL? versus jet stream in this situation?
Yeah, it could be, again, IVL and eccentric plugs. The proximal one, maybe not that effective. And the distal one could rather be effective. At the end, I think there's maybe a little bit missing data about, at least certainly about comparison of these two devices. And we have good results with atherectomy plus DCB. So therefore, I thought to go here for what I know better.
Can you talk to us about your technique in this case? How you're actually using the jet stream? Blades up, blades down, etc.
Yeah, so very, very slow. First blades down, maybe 2 times, and then blades up. So I did already try to get through the distal stenosis with blades up, but the rotation rate went down. So therefore I switched down again to blades down and did this once again. And now I want to try to once again do this with blades up, always with a protection device. So I never do this without, especially in these calcified lesions. I can imagine that already now we have a very slow flow here on the Profunda. Maybe not a bad idea here to check. Yeah, so that's what we usually see or more. Yeah, that's why I prefer to have an 8 French crossover, because sometimes these filters are so blocked that they do not fit through 7 French anymore. Yeah. Okay, so maybe I continue now a little bit here.
So it looks like there's some debris in that filter as expected, I think, with this. Does anybody on the panel have experience with jet stream? What are your thoughts in this case? Would you use, what's your technique? Can you help, us understand, people that don't use it? What's the technique that you use that's giving you good results?
Yeah, more or less it's the same that is what is performing in the we generally please not enough amount of calcium. You can go directly with blades up, just to save a little bit of time. But currently, just to go in with blades down at the beginning and see how react. In my experience, if there is a lot of calcium circumferential distribution, not always working very, very well. But depends again also on the thickness of the calcium again.
Dan, anybody else?
One of the techniques that the Koreans taught me is for things like this is to use the RX system quite a bit. So as they drill, they'll clean it and they'll work it back and forth. They'll take all those hanging chads of whatever crap and bad humors we develop in the lesion to clean it up. And it's also very useful for CTOs. So you go blades down, blades up, and start cleaning it as you go so you don't create a huge debris field as you come out the other side of a CTO. But this is always, it's not just filter accumulation of debris, but it's also fairly, active vaso whatever humors that are sent downstream to create slow flow.
Would most here just continue on and finish the intervention at this point, even though there's significant debris in the filter, and just deal with that at the very end of the case? Since it's the Profunda right now, it's not it's not going down the leg at this point, so. Comment? Yeah, please.
Yeah. Couple of comments. One is if your filter is completely blocked, and sometimes you see the column like above it even, and that dye stops like a few centimeters above the filter. If you just try to use usual filter retrieval, that's not going to be a good idea. So what sometimes helps, you can take a coronary guide, like I use a 7 French multi-purpose guide. Bring on the top, try to suck it just using a big syringe. If it doesn't work, connect penumbra and just go forward and suck all this out before you pull the actual filter. Otherwise, if you're just going to try to pull this filter out, it's going to just spill. The whole thing is going to fly down. Simply won't be able to accommodate back.
Just curious, Andre, it's PK. I'm just wondering, what choice, why did you choose the EmboShield versus the NAV6?
Yeah, the Spider.
Oh, Spider, I'm sorry.
Yeah. This is this is NAV6 here. Yeah, I prefer NAV6 here together with the Jetstream. I have the impression that it runs smoother over that NAV6 wire, the long one, the long wire exchanged to that one. Somehow better than the Spider wire. has always
Yes.
been our experience. Yeah. Yeah. So this
tell-
was a magic touch balloon.
Okay.
Zeroldum was 640.
640, okay.
Yeah.
Yeah,
In
can you-
fact, we measured beforehand with IVUS.
yeah, he did IVUS before, yeah. Dr. Finelli will be very happy about that, I think, right? He used IVUS beforehand. Looks like you got significant debulking there, Andre, as expected.
Yeah, not so bad, I would say.
So what's your plan now at this point? What are you thinking?
Yeah, I could take the filter out, but I can also actually leave it here. There's some debris in, yes. Yeah, I'm going to continue with ballooning now of the common femoral. I also did jet stream atherectomy there with blades up. Now, yeah, I think I start with a 7 millimeter balloon, 640 Ballon. We measured there a diameter of 7.6 or 7.7 plus calcium, so maybe it's a little bigger. So first balloon, and then I'll see how it looks like. Potentially then superior, yeah.
6 oder 47?
Or leave it with magic touch. 7 jetzt, 7.
47. Das ist ein 6er Nummer.
7.
Okay, maybe what we'll do, Andre, while you're continuing on, is we'll go through 1 or 2 talks, if that's okay with you, and then come back
Yeah,
to you.
absolutely. Thank you.
Okay, thank you.
Yeah.
Andre, can you hear us?
Yeah, yes.
Can you maybe give us an
I
update, let us know how it's
can-
going?
Yes, absolutely. Hier mal Wasser. We're actually quite far. So we did, once again, treatment with a magic touch in the common femoral artery. And this is, in fact, currently, that is the result. I think it's, yeah, there's maybe a little bit of bleeding into the plaque in the common femoral, but especially the profunda artery, I think, looks very nice. Still the flow, because of the blocked filter, little hampered. So we took the filter out, which was actually that time quite easy. And first I wanted to check here the outflow. So we didn't sacrifice here any collaterals. So all the same. And in fact, now I wanted to show you once again the IVUS here of that lesion. Oops, das geht hier nicht rein, oder? Sorry. Oh, can you switch to the IVUS then? Oh yeah, here it is. No, switch, yeah. Maybe you can show both IVUS and
This is the
angio.
pre?
that
This is the
possible?
pre?
This is the, this is, we did already a run
actual.
here after
Oh,
that.
okay.
Oh, that's already after that. But now my live gain, IVUS. Yeah, so now we have angio and IVUS. Wire is out again, sorry. Talker. Need to take the wire first in once again. Hopefully I don't need here a catheter. Okay, yeah, it's good. So here comes, so this was now the distal profunda, and then we take it here now to the treated lesion, which starts here. Yeah, I think this is no dissections. I think this is absolutely acceptable. And now we come to the...
Andre, are you able to show us the pre-IVUS by any chance? Is that something you could show us?
Ah,
So
yeah,
we could-
sure.
Just for our learning and
Yeah,
understanding.
so this, yeah. Okay, just a moment. Try to do this.
Fallmenü, ja.
Das war dieses hier, ne? No. No,
Stand das Film.
here, yeah. So this here is the pre. This is before treatment, distal profunda. Then, yeah, subtotal profunda stenosis. And then getting here into the common femoral. Also here, also subtotal.
Yeah, I mean, significant debulking of the lesions and obviously significant luminal gain. Andre and his team are obviously experts at this, but it looks fantastic. What's the plan now at this point? Do you even need to put in a stent?
No, I think we're gonna leave it like this. This is afterwards once again, yeah.
And then what's your plan for follow-up at this point, Andre? And in terms of medical management, what's your plan as well? Because we talk a lot about, low-dose rivaroxaban, low-dose aspirin, dual antiplatelet, et cetera. What is your medical management and regimen in this case?
Yeah. In fact, I think, we do after every procedure dual antiplatelet therapy for a month at least. I don't think he needs rivaroxaban additionally. I think there's a very low risk of acute thrombosis, things like this. No, I would just leave him here on plaques. Yeah.
Okay, great case. Thank you for showing us another excellent case, very complex. You're obviously an expert operator. Thank you.